I'm Arvind Bhimaraj, and I'm one of the heart failure cardiologists here at Houston Methodist Hospital at the DeBakey Heart and Vascular Center. And it's my pleasure and honor to have Dr. David Taylor with us today, who comes from Cleveland Clinic and has given a marvelous grand rounds on the history of heart transplantation and what we've learned over the last 50 years. And it's a phenomenal historical milestone this year that we've reached 50 years of cardiac transplant. Dr. Taylor, welcome to Houston Methodist, and we're privileged to have you.
Thank you. Thanks for having me.
Yeah. And in your talk, you did open up with your inspiration to get into medicine, and your father played a key role in it. Do you remember a moment that really struck you that made you decide to go into medicine? And was it always cardiology from the beginning, or how did you morph into the world of transplant?
Yeah, no, it's. I don't think there was ever a moment that sort of like, as young as I can remember, I was going to be a doctor like my father. I mean, I think that was just, like I said at the talk, he took me to rounds with him on the weekends, so taught me how to read EKGs, and so I was already very sort of ingrained in it. In fact, interestingly enough, he actually discouraged me from going into the clinical side of medicine. He thought I would be better off as a biomedical engineer. So, as I mentioned in the talk, I was interested in the artificial heart even as a kid. And he sort of saw that interest and said, oh, you need to be a biomedical engineer. And so when I was looking at colleges, he was trying to encourage me to go somewhere and do an MD, PhD and be a biomedical engineer and invent the next greatest artificial heart. But I really wanted to be a doctor and a patient doctor. And so I took that course. But yeah, there was never an alternative, and it was always cardiology. Now, when I was in medical school, I got introduced to interventional cardiology because that was right about the time that was just starting. So they were just starting to do angioplasty. And so that was sort of really cool. And as a medical student, I saw that and said, well, that's what I want to do. I want to be an interventional cardiologist. I want to go in and fix something right away. And so when I went to residency, I was going to eventually do cardiology, and I was going to do interventional cardiology. But during my internship, my first rotation on cardiology, Dr. Michael Hess, who's one of the medical fathers of heart transplant, was my attending. And so the transplant patients got put on his service. So all my patients were either waiting for a heart transplant or had a heart transplant. And so all of a sudden I just saw a different side of cardiology. And when I finished my fellowship, or my residency, a friend of mine decided we were going to take a year off. And we were going to work, and at the time they had these, they still have them, these urgent care centers, but at the time they were these little small operations, doc in the box, we called them. And patients would come in for minor things like urgent care, but they had them on corners, and so you could run these. So he and I were going to run a doc in the box, make some money, pay off our student loans, and then we were both going to go back and do our residency. And so, again, Dr. Hess and Dr. Thompson, Tommy Thompson, were like, what are you doing? And we're like, oh, we're going to do this. And Tommy's like, well, don't do that. Come be a fellow, be a heart transplant fellow, because that would be cool, because we didn't have those. And so turned out the doc in the box thing fell through. So I didn't have a job. And he said, oh yeah, let me go talk to Dr. Lauer and see if he'll fund a position for you to be a medical transplant fellow. There were plenty of surgical transplant fellows, but there had never been medical transplant fellows. And so I did that year as a medical fellow, and and then never looked back. And then it was finished cardiology the rest of the way, and stayed in the field.
That's great. I think you've made some keen contributions in the field of transplant, and did a lot of work with the registry, and it was very inspirational this morning talking about the registry data. How did your involvement, or professionally, how did you get involved with the registry data and creation of the whole aspects of using the registry for transplant?
Yeah, like I mentioned in the talk, the registry really started at the same time the society started, which is rather unique. As I showed a couple of examples, it just really doesn't happen that way. But the forefathers sort of recognized that without pooled data, we would never get anywhere in a field where, you talk about MCV and Stanford doing transplants. They would do transplants for a 10-year period when nobody else was doing them, but they maybe did 50 transplants. Yeah. Spread out over 10 years. They do 5 this year and 7 this year, and there was never a volume for them to. So they recognized really quick, we got to pool our data, or we're not going to learn anything. We can talk about it, but there's actually data out there. There's actually science, and we can try to pool it together and show that. Because in those days, the big debate was how to use EKGs to diagnose rejection, and how do you measure the QRSs to come up with. And if each hospital did it differently, then nobody learned anything. So the registry was there for the beginning. So I was lucky enough when I got involved in the society to eventually get a position to run the heart part of the registry. And really, my part was purely administrative, and the registry was already well established, and it was a machine, and all we had to do was ask the questions each year. What do we want to look at? And then we had the statisticians take the database and answer the questions. But we would propose the question, and they would answer it. It really wasn't, as I highlighted in my talk, it wasn't data mining. It wasn't just tell me what's important and we'll write about it. It was we went in each year with a focus. We want to look at the impact of ischemic time on outcomes. So take all this big data and tell us as much as we can about our hypothesis that ischemic time, would predict outcomes with whatever. And so it was a true joint effort. And then somewhere along the course, we opened it up to download so that individuals could request the data. And then within ISHLT, we did it by providing them a little scholarship to help them and provide them with some of the statistical support. So they would submit an application, and we would give the information to them with statistical support. The UNOS STS database, SRTR database, actually allows, maybe 10 years ago, started allowing people just to download the entire data files, but without any statistical help. So then you have to go through there and do it yourself, but you have all the data, right, which is good and bad. If you don't really know how to deal with it, you can create a disaster. Yeah. But if you do know how to deal with it and do it right, it's entirely up to you to take the data and answer your hypothesis.
Yeah, I think that the registry data probably is the most comprehensive outlook that we get in transplant, with so much variations in each center. Right. To your point, you're absolutely right in that.
Yeah, the variation is huge, and you just can't. Single centers can't. They have deeper data. So if you really need to dig down really deep, all the registry data will be snapshot data. So at 1 month, at 1 year, at 2 years. So a lot of what happens in between, it's not all event-driven data. There's some event-driven data, but a lot of it is snapshot surveillance data at time points. So it is hard to get too granular with details. What was their immunosuppression dose during this time period? Well, you may or may not have, you may have what they're on, but you don't have doses and levels.
Right.
So there's some information you just can't get, and single center is important because you have that information. But there's so much that single center studies just can't answer because they just don't have enough data.
Yeah. And one of the limitations, at least I personally feel in advancing the field, is the variations in so many centers in what they do. And in that regard, if resources and money were not an issue, what would you think we should construct to have a unified way of advancing the field in learning the science of transplant, either the biology or the logistics? What would be the vision if money was not a limitation?
Yeah, that's a great question. It is, it's one of the subspecialties, as you said, that's it's an art and not a science. We haven't figured out the science enough to where, and we all have cookbooks, we all have institutional cookbooks. Here's the way you treat a transplant patient based on sort of the best guesses by the experts as to what you should do. But it's never in enough detail to really do it consistently, and each center has their own cookbook. That's a slight version of somebody else's cookbook, but the ingredients are different. So we're not going to end up with the same cake with all these centers because everybody's got slightly different ingredients. But that may not be a bad thing, right? I mean, there's probably a downside to being too prescriptive and too regimented. All the cakes look alike. And if you baked a bad cake in the beginning, everybody's baking a bad cake. Whereas if everybody's doing it a little differently, you can learn, well, that cake was really good. Maybe we should look at how they baked it, and we should take the best of what they did and get rid of the worst of what we did, and we can actually improve. So I think that individuality is necessary to move the field forward, because somebody's got to think of outside the box. Somebody's got to question, the dogma, right? And so we've got to push on individually, but at the same time, you're right. It's helpful if we can, if we can share best practices, if you will, right, in a way that, and I think we do. But and registries help you from the informational point of view because they'll smooth out the practices. Yeah. You can explore things in large volumes to patient care even. Should you be on this drug or that drug? Right. Well, that will depend on the institution and their protocol, but if you look at 20,000 patients and say, look at all the ones that were on this drug and that drug and compare the differences, you kind of level off how the drugs were used at individual groups. And you would hope, just from the law of averages, move to the mean, that basically the effects will be similar. And so then you can actually compare the two drugs and say, oh yeah, head to head, they look like this versus this, even though you know that in the individual groups, the use of that drug was very different between center A and center Z. But you hope it averages out so you can answer a question about the drug, not about the use. But you have to recognize that you can't comment about the use, the individual use. So you can, but once you identify that, hey, drug A appears better than drug B, then you can go look at drug A and then try to tease out the use if it's in the database, or go to multiple centers and say, we'll take 10 centers that represent the group, and then we'll ask them to get more data so we can drill down. So I think registries can answer primary questions, but they can also, more importantly, create hypotheses. Create a hypothesis that you didn't think about before because you didn't have the data to drill down that deep, and then say, oh, here's a dilemma that we haven't answered and we can't answer with a registry. We can identify it, we can highlight it, but we can't answer it with the data. We need more data. So now you go to 10 centers and say, let's get more data. And let's try to answer this question that we can't answer at an individual center because we do things one way.
Yeah.
And all of the patients are uniformly treated this way, and so we won't answer the question about what's the best way to treat them because they're all treated the same. But at 10 centers, we can compare or whatever.
That's fair. I think that's a valid point. We don't think about it because the variation enriches your practices and then to move on. You did reflect in your talk today on the difficult situation of balancing your ethical responsibility for an individual patient or being a steward of the field. And you were at the highest of the stewardship, being the president of the society. How did it change your perception, or did it not, the year of tenure that you led the society for the field? Do you have words of wisdom for us in how that changed your perception in being the steward and balancing that act as an individual physician?
No, I think it definitely does. And not just at the, you could argue it like I was pointing out the patient care perspective. I'm advocating for my patient. I always, as you guys do here, you have these multidisciplinary meetings where you discuss patient, whether they're a good candidate or too high risk a candidate or not a candidate for a transplant or a LVAD or whatever. And I've always said that whoever's presenting the patient needs to argue for the patient, right? You need to argue that this patient is going to die without this procedure. Here's the statistics. Here's the risk with it. Here's the risk without it. He will die without it. Therefore, I'm going to advocate that the patient get the procedure. But somebody in the room has got to be advocating for the other patients who aren't going to get it because this patient did get it. So somebody's got to represent the group, and then you can take that one step further and even get out of the room and say, but somebody's got to argue for all the patients because your patient in Houston is competing for the same heart as my patient in Cleveland. It's not just my patients in Cleveland competing for the same heart. They're competing with your patients. So who's going to stand up here? And that's hard because as a physician, you're the patient advocate. So you got to take off your physician hat. And the same is true for institutional priorities, right? So as president of the society, I got a good perspective of I'm not arguing for the Cleveland Clinic. I'm arguing for transplantation in general. So I need to make sure that I'm speaking on behalf of the transplant community, not on behalf of Cleveland Clinic, or not on behalf of United States policies and procedures, but international. Right. So it was very enlightening. I learned a lot about being able to step back and and govern, so to speak. That it's not about you as the individual. It's about what your role is within the society to help the society be better, not just your center or you as an individual. That was a great experience, but words of wisdom to how to it's recognize the biases, recognize the conflict. There will always be a conflict, and recognize it. Be transparent. I am biased for this patient because I'm his doctor. I think this is best. But I recognize that as a hospital, as a program, as a country, maybe this isn't the right decision. I can recognize that, as opposed to I'm only speaking on behalf of the patient without any recognition of the other competing forces.
Yeah, that's great. And you've seen the field of advanced heart failure pretty much evolve from just being transplants to MCS and technological advancements with things like remote monitoring. The field has kind of become so broad. What is your advice for the current and the future generations? How to be a great physician, I almost feel like you always instill the principle, be a great internist, then you're a cardiologist, then you're a heart failure advanced practitioner. But that's becoming challenging day by day.
No, it is. And over the course of my education and uneducation over the years, yeah, I agree. It's getting harder and harder, but that's not just true of heart failure, it's true of interventional, it's true of imaging, it's true of any subspecialty of any big field like cardiovascular medicine. Surgical, I mean, it's, you know, at the clinic we have mitral valve experts and we have aortic valve experts, and, you know, we've driven, you know, all the way down, but even those experts do other operations. They don't want to just be a mitral valve. They may be the go-to mitral valve person, but they can also do a bypass and an aortic valve and an aortic dissection. So it's you got to be careful not to niche yourself down too much, because the next technology may put you out of business.
Yeah.
And I think that's true on the medical side as well. You don't, you know, it probably is not in your best interest to be the best transplant cardiologist that ever lived, because your impact may go away once something changes, right? Once the LVADs get really good, then all of a sudden you're not important. And like you said, the technology rapidly changes. And so, you know, you got to be able to keep up with it. But I think at the same time, you've got to be a little nuanced. You know, I've looked at LVADs. I wrote a paper on them when I was a kid. I've watched them evolve. I consider myself very interested in LVADs. Maybe an expert in LVADs, but I don't feel like I'm an expert in LVADs. I've got to have colleagues that know more about it than me, that I can go to and say, help me with this. So I think, you know, we do need to compartmentalize a little bit so that we can keep up with the technology. But at the same time, you know, my advice is always don't put your eggs in one basket, because that technology may be gone in just a few years. And then you've limited yourself. So to be a good heart failure cardiologist nowadays, you really do have to understand. It doesn't mean you have to practice LVADs. You have to be at a center that does LVADs, but you need to understand LVADs. Mm-hmm. You need to understand who to send for an LVAD, and who to not send for an LVAD, and when to send them for an LVAD, even if you're not taking care of the patient yourself. So I think you've got to keep your knowledge base up there to know who's the right candidate for a transplant, when to send them, same thing. Yeah. So I think you can practice all levels of heart failure and be very competent and be very good and do a great job. But you've got to be aware of the technology and what else is going on. You know, when do implantable devices, monitoring devices, when are they helpful? You know, if you don't really understand the device, you don't really know who to refer for the device. Yeah. So, you know, I think all that, it's a constant education and re-education.
Well, thank you. Words of wisdom that will definitely you know, pass along. Like you said, history will teach the future. Thank you for your time, and hope you have a good time here at Methodist.
Well, thank you for having me.
Thank you.
Yep.